So dear Chairman, dear audience, let me greet all of you and allow me to present my progress regarding my PhD topic. I am Hajnal Székely, working as a medical doctor at the Department of Surgery, Transplantation and Gastroenterology. As a PhD student, I have Pál Miheller as my supervisor and Anett Rancz as my SMS. My vision is to improve the quality of IBD patients' care by extending the knowledge regarding several important aspects of this complex systemic disease. Within our project, we have two goals, basically. We would like to assess the role of certain medications in two major complications of IBD, namely venous thromboembolism and IBD-associated colorectal cancer. It is well known that patients with IBD are considered to have a 2 to 3-fold increased risk of venous thromboembolic events compared to the general population. So the prevalence of this complication, it is considered to be between 1 and 8%, but it is known to reach as high as 40% in post-mortem studies. If this complication appears, it is considered to be a relevant cause of morbidity. It results in longer hospitalization, has a tendency to recur, and most importantly, it may be fatal. The mortality rate of these events, it is reported to be vary between 8 and 25%. As a complication of IBD, venous thromboembolic events are primarily a consequence of the inflammation, but despite the fact that lately, during the last decades, we have newer drugs which target to properly control the inflammation, still neither the rates, neither the mortality of these patients decreased significantly, so this underlines the current relevance of the topic. Venous thromboembolic events are considered to be multifactorial in IBD, and besides unrelated factors, we have here disease and treatment-specific characteristics that should be taken into account, like extended disease in ulcerative colitis, colonic localization and fistulizing behavior in Crohn's disease, active disease flare-ups, and consequent hospitalization in both disease phenotypes. Treatment-related risk factors with proven effect are the surgery and the need for corticosteroid treatment. Considering other treatment options available and their relation to venous thromboembolic events, the data are relatively scarce. Tumor necrosis factor alpha inhibitors are known to be effective in inducing and maintaining remission in IBD, and also to decrease the need for hospitalization and surgery. If we take into account the fact that TNF-alpha, it's a pivotal molecule, not just in the inflammatory process, but also may activate the coagulation cascade, we may presume that inhibiting this cytokine, we may interfere with the coagulation also. So our aim was to determine and compare the role of TNF inhibitors with conventional IBD therapy on the venous thromboembolic events risk. For the clinical question that we formulated, we used the PICO framework with the hypothesis that TNF inhibitors are associated with a decreased odds of these events compared to conventional therapy. We conducted our systematic search in 5 databases at the end of November, with the search key containing the domains of the disease, of the complication, and also of the chosen biological drugs. Out of more than 10,000 hits, we were able to include 18 articles, but these articles were mostly observational cohort and case-controlled trials, because randomized controlled studies are not available in this topic. To compare the effect of certain medications on the venous thromboembolic risk, we choose the odds ratio as a measure of effect, and an odds ratio of 1 means that there's no difference between the effect of the interventions. When we compared the rate of these events in patients treated with biologicals versus those on corticosteroids, the odds ratio turned out to be 0.42 in the favor of the biological drugs, and this difference was statistically significant one, meaning in the clinical practice that in cases of those patients who have active disease flare and considered to be at high venous thromboembolic risk, the TNF inhibitors should be preferred over corticosteroids. To decrease the imprecision of our data, we also determined the proportion of these events in the mentioned treatment categories, showing again that those treated with TNF inhibitors are less likely to have this complication compared to those treated with corticosteroids. So we used the same methodology when we compared the rate of these events in those patients treated with TNF inhibitors and immunomodulators, but here neither the proportion, neither the odds of these events did not show statistically significant difference. And similar results were found when comparing those patients on biologicals and aminosalicylates. So basically, during our work, we assessed the possible effect of the most commonly used medications on venous thromboembolism and find out that the anti-TNF alpha drugs should be preferable in those patients who are considered to have high venous thromboembolic risk compared to corticosteroids. Obviously, there are many limitations to our work, as the included studies are mostly retrospective and observational studies. It is well known the large heterogeneity of the IBD population. It is also important to be mentioning that there are many confounders that should be taken into account when we try to assess the effect of certain factors in the compound venous thromboembolic risk. And also the concomitant medication, which is a regular practice in those patients, in IBD patients basically, it makes really difficult to address the exact role of certain medications individually. So for these reasons, there's a very low certainty of evidence of our data. But we would like to raise awareness of this complication and underline the importance of the so-called steroid-sparing therapy in those patients who are considered to have a high venous thromboembolic risk. And also to point to the future as prospective, large, well-conducted and well-designed studies are needed to assess the proper effect of certain medications on the compound venous thromboembolic risk. At this stage, we finished the manuscript writing. We are over the internal review, the language check, and the plagiarism check, and we also send out the inquiry letters. Regarding our second project, we choose to assess the role of medication in IBD-associated colorectal cancer. It is well known again that these patients, compared to the general population, have a around twofold increased risk of colorectal cancer, which may appear at a younger age compared to the sporadic form of the disease. It may be most commonly multifocal, and as a prognostic value, it accounts for 10–15% of all patients' deaths. Here also risk factors are known, but basically it is important to underline the fact that the dysregulated inflammation, it is considered to be the basis not of just the IBD, but also of the carcinogenesis, which follows the inflammation dysplasia carcinoma sequence. So our aim was to compare the role of certain drugs on the IBD-associated colorectal cancer based on the fact that by achieving long ongoing remission and mucosal healing, we may interfere somehow with the development of these malignancies. So you see here the clinical question, and again we choose the PICO framework, and the hypothesis is that these biological drugs may decrease the odds of IBD-associated colorectal cancer. We build our search key, again containing 3 domains of the disease, of the malignancy, and of the chosen biological drugs. And you see here the number of hits, but the data collection is still ongoing as we speak. So in summary, during our PhD thesis, we chose to assess the role of biologicals, tumor necrosis factor alpha inhibitors, and compare them to conventional therapy in 2 major complications of IBD, venous thromboembolism, and IBD-associated colorectal cancer. I'm thanking you for your attention, finishing with my quote and waiting for your questions. As the scientist is not the person who gives the right answers, he is one who asks the right questions. Thank you.
I am not sure about that, but I remember you had some discrepancy in the data in the first project. How did you deal with that? If there was some issue about the patients getting double therapy and some single, How did you deal with that?
So it is a common practice that the majority of the IBD patients have concomitant therapy. Just a small fraction of them need monotherapy or are well or in remission with just a single drug, basically. So all of the articles that reported the venous thromboembolic events compared or assessed in the regard of medications, they just published the number of these events and also the number of patients on certain medications. And obviously, if we add the proportion of patients treated, is going to be higher than 100% because the majority of the patients are going to have not just one medical treatment or medication to have a proper control of the activity of the disease. So that makes it difficult to assess properly, and also that's the reason also why we don't have randomized controlled trials, because it is unethical to randomize patients in this regard. So these are the limitations to our work. Still, we have previous data which are telling us the same results published years ago, that TNF-alpha is preferable over corticosteroids in patients with high venous thromboembolic risk. There were really limited data till now regarding the possible effect of certain other relatively frequently used medication in patients with IBD. So that's why we tried to assess or to summarize the available data in this regard.
So the results of your first project raises the question whether you should be giving anticoagulation as a preventative measure to patients who are actively inflamed and who are on a medication which comes at a higher risk of VTE than the others, even if they are ambulatory patients and not admitted to hospital. What do you think about that?
So there is a current ECHO guideline, not published yet, just a manuscript accepted at the Journal of Crohn's and Colitis, which states that all of hospitalized patients who have active disease flare should receive prophylactic dosage of LMVH, just exception being those who have severe bleeding. Otherwise, all of the patients should receive it. Obviously, it's a question whether, as we send home these patients, should we continue the prophylaxis or not. There's a debate yet. Obviously, not all of the patients should be getting this treatment, but there's a small fraction of patients in whom it should be given, most probably those in whom the compound VTE risk is increased. So not just the IBD is going to be considered a risk factor, but there are many others also. And as outpatients also, there's a fraction of patients who should have getting LMVH prophylaxis, but we don't know precisely who those patients are. So the evidence level is 4 in this regard in the newest ECHO guidelines. So it's something that should be...
already is changing the practice to a degree, but there's a lot more work to do around research.
Yes, it is still work to do, yes.
That was my question, but asked much more eloquently.
How would you account for the inflammatory burden during the different therapies when you are comparing the thromboembolism risk? Because most likely there is a correlation between the inflammatory burden and the thromboembolism. And it also should somehow accounted for if you are comparing the different therapies. Can you equalize the groups? They have the same inflammatory burden?
Sorry, I did not understand your question precisely.
Yeah, maybe those patients who are also receiving steroids in addition to other therapies, they have more severe disease and more inflammatory burden. That's why they have larger risk of developing thromboembolism.
So I consider that, so what we learned here, that besides the IBD and the activity of the IBD, which obviously it's of importance in the regard of VTE risk, what we are learning here that there are other factors that should be also taken into account when we try to assess individually which patient is going to get prolonged prophylaxis and which patient is going to be just receiving this therapy during hospitalization. Obviously, anti-TNF drugs and corticosteroids during hospitalization, both of them are given during active disease flare. So the difference between choosing, it's going to be related not just based on the activity of the disease, but most probably taking into account other risk factors also.